celebrate us, let's celebrate each other.
We need to include perinatal perspectives. Be kind or be absent.
Let's bring back the village.
I'm Leah Lewin, the perinatal specialist.
Have this conversation with me. I'm sure you're very busy and I really appreciate your time. And also, of course, just all of the work that you do in terms of like education and just contributing to making a better space for mothers and just Black maternal health in general. I think it's incredibly commendable and inspiring, and I love what you do. To start with, I can tell you a bit more about my research project if you'd like, so I can just give you a bit more context. I'm kind of, the overview / title that I've given it is just looking at the power of advocacy, specifically in the NHS, within marginalised communities and in a clinical environment. And so particularly this subsection of the report, I want to look at Black maternal health and how that affects Black women specifically. Some of the other points that I've been kind of covering have been, of course, what is the importance of advocacy in kind of the clinical environment, and kind of the importance of having healthcare professionals who obviously mirror you in terms of the way that they look, and then their experience in the report that kind of that can add, and how that improves patient experiences. I was also looking at different ways to kind of promote advocacy, and for example using a patient-centered approach. And then here obviously we're looking at advocacy in Black maternal health, obviously during pregnancy, after pregnancy, and pre as well. And then at the end of my report, I also want to look at the mental health of ethnic minorities and how advocacy can kind of help to improve that or stunt that further. So if you keep seeing me look at my phone, sorry, I've got the questions on there.
No problem.
We can start with the first one is, how does your training directly challenge and dismantle any racist stereotypes or knowledge gaps, do you feel?
I didn't hear the end of the question, sorry.
No worries. How do you feel that your training that you offer directly challenges and dismantles racist stereotypes or knowledge gaps?
Oh, how does it dismantle? So the primary focus is on, rather than seeing everyone as whole, seeing everyone as individual, and focusing those experiences on people that are marginalised and minoritised. So taking a different lens, different approach, and appreciating the impacts of not only the biases of healthcare professionals, but of those that they seek and support, and how the religious, cultural, philosophical beliefs all impact their behaviours, attitudes, as well as those that they're caring for. The training itself is, it depends which one you're talking about, but the various trainings.
What types are there?
So I co-authored Free from Harm with Amity Reid, which is about the elimination of obstetric violence, which again, this has caused and still continues to cause a lot of controversy because people don't like the term obstetric violence in a nutshell. Now, obstetric violence is not about the status or the gender or the role of the person performing it, which is why sometimes it's misconstrued as something that happens from that it's only happens when you're working with an obstetrician. That's not the case.
Okay, yeah.
Any healthcare professional can. It's about the physical, emotional, mental, and institutional abuse rather than physically holding someone and abusing them. So it challenges their beliefs in language. I actually just came off a meeting with an obstetrician, and I was asked a question about using such language because it's offensive. And my stance on that is, I don't want you to be offended by the terms and the language. I want you to be channeled that energy and that same frustration to the actual experiences. Be upset that people are experiencing this violence, this neglect, this abuse. Not that you don't like the language around it. It's not calling anyone out unless you're a perpetrator.
Yeah, completely.
So it's conflicting, and it sometimes goes against the mandatory training that's received, and it really focuses on the perspectives and experiences of those that have been harmed and those that are accessing care. I also have training on intergenerational trauma and how that manifests in the perinatal period. Again,
I saw writing a book on that. Yeah.
That book. Yeah. It's a challenge. I thought I started off with 26 chapters. I'm now I started with 13. I'm now, I think, 43. And
really, wow.
I just added in a couple of topics, one on intergenerational trauma and the interaction with animals, intergenerational trauma and the adverse childhood experiences when it comes to adoption. And also, third one that I just added, there was another one. So yeah, it's really complex. I also provide more bespoke training for hospitals and universities around inclusivity, being fully trauma informed, which again, that includes intergenerational trauma, because it's not recognized certain behaviors and characteristics manifest from intergenerational trauma. And if you're not identifying those and those behaviors, then you can't say that you're fully trauma informed, because you're not going to be able to recognize it, especially more so when it comes to Black and Indigenous women, but also from the perspective of the descendants of colonizers, for example. It's not just about enslaved people. We see that through epigenetics, trauma is transmitted. However, that's for everybody. It's not just those that were enslaved, for example. It's everyone, and the impacts of what's happening globally in society, from war and destruction to epidemics to just about everything, climate crisis. It all impacts, and it all comes back to maternal health. And unfortunately, as Black, Asian and Indigenous women, we are more susceptible to adverse outcomes from conception to death. And that is also when you look at the impacts of menopause, how that then impacts us, but because of society and cultural beliefs, it then transpires into something else a little bit more challenging. It challenges our mortality and morbidity rates more than our white counterparts consistently from birth. And those conversations, the trend right now is around maternity, but we need to look at the longevity of health, from our reproductive health from start to finish. Sorry, I feel like I may have gone off topic.
No, it was great. It was amazing. That takes us kind of nicely onto the next topic of how important do you think advocacy is, and what way do you think it should be best practiced?
That's a very good question. So the first part, I think advocacy and expert by experience needs to become more of a priority when it comes to the education of healthcare professionals, because allies are now more sophisticated. And by that I mean,
when you say allies, do you mean more like patients and people who are receiving services, or the trusts?
I mean families, friends, people that are concerned, not necessarily the healthcare professionals, but everybody else. Remember that the healthcare professionals go through an education system. And then they are then grounded by guidelines and policies that keeps them in line with the education. If you want to go outside of that, it's self-seeking. It's not something that is necessarily easily accessible for all. Especially again, if you're thinking about those that are minoritized within the healthcare system. So the allies that are providing research, that are having open conversation, that are working with communities and organization and grassroots foundations, they are now at a point where they are working to uncover more truths. They are listening to people's lived experience, and they are shouting louder.
Mm-hmm.
So I think having someone within communities to ensure that everyone's voice is heard
Yeah.
needs to be prioritized within the healthcare system, most
Yeah.
definitely. Where is a very good question. I'm trying to figure out the answer to. It would be wonderful if it was within every trust, every hospital,
Yeah.
and every community when we're talking about midwifery or even obstetric-led care. Unfortunately, we're not in that position to do so, and that I wouldn't blame that on guidelines. I'd just blame that more on capacity.
Yeah.
But I think within the next 10 to 15 years, I can't see it happening in any less than that. MNVPs need to be more representative and utilised to actually connect the communities with the healthcare professionals. They've made a great start, and the impact on guidelines. There are certain hospitals, for example, Rosie Maternity Hospital in Cambridge.
Mm-hmm.
They are great at working collaboratively with the trusts when they're developing guidelines on things that service users have expressed as priorities. So the
Yeah.
communication of consent and choice, that's something that has been a collaborative effort. The impacts on Black and Asian mental health, that is something that is a collaborative conversation rather than the guidelines being written from a medical or clinical perspective. Is becoming more person-centered and patient-focused.
Yeah. Mm-hmm. The next one is, how do you think NHS resources, distribution and facilities can be improved?
Accessibility. So specifically focusing on the UK, the accessibility really varies, and that's almost like a geographical lottery.
Yeah, that's one of the questions that I had here as well.
If you are in somewhere like London or Birmingham or Luton, then you are more likely to have translated services and resources in the 5 most common languages within that area. However, if you're in somewhere like South Wales, I've personally identified that an anaesthetist will say, "Oh, we try to gain consent, use hand gestures, or try to mimic actions and things to inform them what's going to happen." That's not informed consent because they're not fully informed. They don't have all of the information, and it's not being communicated effectively. You don't have the right communication aids. Well, the funding isn't there because it won't be prioritized, because they may only have one person that doesn't speak English come in every 3 months. They may only experience 2 asylum seekers every 7 years. They may only have one Nigerian mother come in who is a refugee that they're not prioritizing because it's not somewhere that they have a large demographic of people. But actually, if one woman was to die, so for example, if we look at the Panorama series that aired at the beginning of this year, if one person was to die in that hospital, yet you have hundreds of thousands in London that are safer because there's translation services, the focus needs to be on the one person that died. So the disproportionate access to resources needs to be prioritized everywhere. There is that information available, it's just not accessible to all trusts. Therefore, if we could, and I know that it's an unreasonable ask because it's still a business, if they could be shared across trusts.
Why is it not accessible to all trusts?
Money.
Oh.
Money. the NHS is a huge business, and
Mhm.
it's, I don't know if you can use that, it's factual, but controversial. It's, there would be other priorities
Yeah.
because of the systemic and institutional racism. There is no way that I can foresee, although there is a lot of conversation around it, supporting somewhere like Wales to have interpretation services and spend budget
Mhm.
on these resources of information in various languages or in Braille if they don't have that demographic of people, because it's a costly investment.
Yeah. Yeah,
And
definitely.
one life, unfortunately, is not seen as of as value because of the systemic racism.
Hmm. Yeah.
Now, if we were to reflect that as one Caucasian male within a powerful position in society, the narrative would be different. And that's how we're able to identify the racism.
Yeah, definitely. Hmm. This literally leads on perfectly to one of the next questions, which was it was non-English speakers are 25 times more likely to die in pregnancy, birth, and postnatal care. How do you help or feel like we can contribute to overcoming language barriers in critical moments, more so healthcare professionals than normal people? But yeah.
So this one I actually feel quite conflicted on,
Okay.
because they're, with the development of technology, things have become more accessible.
Yeah.
So, for example, the introduction of AI could be
Mhm.
utilized to draft resources for translation and for Braille and for hearing impairments.
Yeah.
However, that leaves room for error because they are not sophisticated enough to ensure that when they are translating various dialects that the meaning is not lost or that it's efficient when it's translated.
Mhm.
So it would still need to be reviewed by a human. However, using that to maybe expedite quickly and prepare drafts, I think can be really beneficial in the short term so that we have something readily available to provide to interpreters and translators
Yeah.
for them to
Mhm.
just finalize.
Yeah.
How else? So for grassroots organizations, I think it's part of an upcoming project, so I don't want to give too much away. I think that providing education, first of all, we need more interpreters,
Mhm.
and schools, that needs to start in schools. The sign language and various languages needs to be prioritized, and in England, in the UK, it's not.
Yeah.
So that's probably the first one. Then moving through from that education, providing providing translation services are normally provided by minoritized or marginalized people.
Yeah.
The investment isn't there, which leaves them redundant. Yet the services are required and they will be utilized. So again, decolonizing the education around that and providing some sort of equality in education and employment would
Mhm.
be the second stage. And then lastly, if that comes to fruition, having them within the community groups, working with allies, working with the local trusts.
Yeah.
So almost as the middleman,
Mhm.
if they are able to be that middle person, they're accessible to all.
Mhm.
So even if there was a localized community group which was set up to hear the voices of Black and Asian women, having a translator available so that when we're trying to form these partnerships and work in collaboration with hospitals and even the government, there's a smoother transition of information.
Yeah.
And providing that partnership in a triad so that everyone can achieve a collective goal.
Yeah. Very nice, thank you. The next question is, how does rebuilding trust between marginalised communities and professionals impact people you work with or just general clients / patients of the NHS?
How does it, or how should it?
How does it?
Trust.
Mm-hmm.
The main thing, it builds trust.
Yeah.
It increases safety, because if there is positive communication, there is more openness. If there's more trust, then there's more disclosure. If there's more disclosure, there's more transparency. And when we have transparency, there is more effective care.
Mm-hmm. Epistemic injustice prevents poor communication of ideas or experiences, leading to bias, dismissal, and ultimately undertreatment. Do you feel like this is common with the people that you speak to, be it both professionals and patients as well? And how do you think it should be addressed?
Yes, in a nutshell. And that is from both sides. So health professionals that come from the same communities as those they serve, and also the service users and patients. How should it be addressed?
Mm-hmm.
The only way it can be addressed is through the elimination of racism, and that is through mental health support, education, and providing opportunities for those that are oppressed to have their voices heard, but equally the oppressors need to be able to acknowledge and understand. So they need to listen, but they also need to share their stories. That can't be done as a collective because it will cause more harm. But at the moment, there is a lot of bias, which is disguised as unconscious bias, which people are then using to suppress their beliefs out of fear, which means if you can't confront your own beliefs or inherent beliefs, it's very difficult to then challenge them and reframe them.
Yeah.
So, for example, if we're talking about misogyny, that's a hot topic at the moment. If we have a group of white men that devalue and maybe criminalize Black women, they need to understand why.
Yeah.
Because us saying that misogyny is bad isn't enough to reframe all of their inherent beliefs, things that have been passed down for generations, that are ingrained within them. Saying that's bad, don't do that, doesn't even work for a child.
Yeah.
So we can't do that. But then it cannot then be a Black woman's position to educate them, because that's unsafe.
Completely agreed, yeah.
So it needs to be a case of they are able to engage openly in these conversations so that an ally or professionally trained ally can then speak to them, hear their version, speak to them, and help to then, with whether it's using therapies or additional talking practices, or simply education and pictures and diagrams, educate them on why it's wrong, how it impacts them negatively, how it will impact the future generations.
Yeah.
And how to then change their racist and misogynistic views.
Yeah. Thank you. That was very nice. Or good, rather. Not nice. Nice is
nice is probably not the word
not nice. Yeah, sorry. The next question is, how does your organization contribute to improving cultural competence amongst professionals to reduce bias?
Education, conversation, and therapy.
Therapy is an interesting one as well. Yeah.
So currently CBT, EMDR, coaching and consultancy is my specialty.
Yeah.
But also sometimes in a really simplistic way, listening.
Yeah.
Just listening, because with some clients, allowing them to say it out loud, sometimes that's all they needed.
Yeah.
To then,
like, safe environment as well. Yeah.
Yeah, for them to then recognize and acknowledge what maybe needs to change, or what needs to be enhanced, or what needs to be reduced, and then we can have conversations following that.
Do you think that there should be kind of some work that has to be done in terms of the accessibility that therapy should, well, rather what I'm saying is that therapy oftentimes can seem inaccessible to people.
Yeah.
And so how do you think that can be kind of deconstructed to become a bit more mainstream in terms of its accessibility for people?
Funding. It's all money. Everything is money. Everything is money, everything is business. And I had quite an altruistic view when I first started, of wanting to change the world and help everybody. But then it's kind of having to dismantle my own beliefs, and my own generational transmitted traumas and beliefs, that I have to be the one to fix it. Actually, as a Black woman,
you also do that through therapy. Sorry.
No, say again.
Did you also kind of had to deconstruct that through therapy as well? How did you kind of get through that?
Yeah. And being able to identify myself within others was a really key turning point for me, because same actions, same beliefs. And I know at this point, although my work is still a business, it's not my responsibility. I think sometimes that can be the downfall. The burden of responsibility needs to be distributed equally.
100%, I agree. Yeah. And do you think over the course of kind of your career, like pushing towards equal rights and Black maternal health in that space, that you've become more of a pessimist? And how do you feel like you've had to fight that, if you have?
I don't think I'd say I've become a pessimist. I think it's more acknowledging the realistic elements within it. But I mean, if I became a pessimist, I'd have given up.
Yeah.
There has to be an element of that. You have to have an optimistic view that
100%.
there can be change. Otherwise, every conversation, every action, every written piece, every study, it would be pointless. I wouldn't be participating in any of it.
Yeah.
So there is a great level of optimism, and I guess the prioritizing the closest achievable point has to be key, because you have to achieve something in order to want to be consistent. So prioritizing the achievable goal. So what can I do imminently? There's a WhatsApp group developing where I can share knowledge and support there. Giving back, that's not at a cost to anyone. There's a membership group where people that want to delve a bit further, and they're at the point where you've had free access, but you've learned a little bit, it's resonated, and now you want to develop your understanding more, and you're ready to do the work, because if people aren't ready, they're not going to do it.
Yeah.
And then you kind of step up. There is then the education and resources, and that community there, they are active members that then want to go on and share with their networks and share their newfound knowledge and understanding.
Yeah.
And that's how you each can do everything, rather than me saying, no, I'm gatekeeping this information, I want to do it.
Yeah.
That doesn't serve anyone, because it's at a detriment to those that are still suffering. The quicker and more efficiently we can get the support and information out there, the quicker we can reframe people's minds, the quicker they can then impact departmentally, the quicker it then reaches to the top, and then maybe institutional impact
and change. Yeah.
And then we can affect policy change and things like that. That is the goal, but that's not an individual burden. That's something that we do collectively.
100%. Sorry, we went a bit sideways. That was just my own personal question. I was just
That's right.
The next question is, are there any particular success stories or case studies that you can share where you feel like where there has been wait, let me say that again. Sorry, I've jumbled up the words. Are there any particular success stories or case studies that you can share where interventions have significantly improved outcomes for Black mothers?
Interventions of what sort? Do you mean like augmentation, induction, that sort of intervention, or mental health interventions, community?
In any way that you take it, really. So maybe we can cover all of those points.
Okay. It's interesting because intervention, again, and everyone has biases. I have my own biases. It's important that we identify them. My bias is that I don't necessarily believe intervention when it comes to physical intervention and physiological birth should be prioritized, and I don't always see it as that helpful. However, I know that there is a necessity there in some cases. So I'm trying to think of, there was a hospital that I worked, that I'd never worked at before. A Black mother, first live birth. Her family have had experiences of trauma, obstetric violence, and baby loss. And it was a very long birth, but the long and short of it was this mother ended up having a cesarean through intervention, and that was because augmentation wasn't a priority for them at all. It wasn't necessarily safe for them, and having an assisted birth would have been more harmful because of previous abuse. So having a C-section then meant this mother had a more positive birth experience because the time had elapsed, and because of the hospital's perception of their policies, I had a bit of a challenge explaining or identifying her rights to them, which led to a bit of a disagreement, but I was able to get my own way in the end on the mother's behalf, and she went straight to cesarean after deciding she couldn't face the challenges of physiological birth. So that's one time that a physical intervention has helped or had a positive outcome. Mental health, I would say, don't want to give any identifying factors. This birthing person and a close relative were birthing at the same time. They were both my clients, very different circumstances of birth. One had a child, one didn't. They both carried a lot of fear because of the first person's first birth, sorry. And because of that, the one that was due to birth second had a lot of anxiety because of cultural beliefs, didn't want to medicalize at all, didn't want any pharmaceutical treatment at all, didn't believe in it, didn't agree with it, and even with education around it, it wasn't an option. We had an odd number of sessions. I can't remember how many, but it was definitely an odd number. It wasn't 6 or 12. It was very random. And I got there the day of the birth, and we had one last session, and it was like the light bulb moment. And I honestly believe that's probably part of the reason they went into labor, because they finally relaxed and let go and had a beautiful birth. I actually received some more pictures. the child is preschool now, and
Yeah.
it's crazy. So like I got school photos of a couple of my other birth babies, and it's so that they were both very positive experiences. But the turning point was the day before. Well, actually, she went into labour that night. So the day of
Yeah.
the labour, and it just goes to show that it may not be in a pill form, but sometimes, and often so, therapy is just as effective as a drug.
Yeah. Yeah, I love that. And that also must be just so fulfilling as well to see the pictures and how
That's
things
what
go.
you get, the warm fuzzy feeling. So
Yeah.
yes, this work is very hard. It's very emotionally taxing. It's
Yeah.
really emotive, and it's very heavy at times. But the other side of it is beautiful.
Yeah, that's also kind of where my intrigue about the pessimism came from as well. I feel like surely it's partially a little bit inevitable for you to take some of that work home with you and for it to affect your mental health.
Which is why therapy is important.
Yeah. Yeah.
Yeah. And reflective practices. So not just having a cup of tea and having a bath. That's not
Yeah.
what self-care is about. It's also about your persona. It's also about setting boundaries. It's about
Definitely.
knowing how to navigate interprofessional relationships and using key skills. Like a lot within pretty much all of the trainings, I use graded assertiveness tools and understand whether you're being passive aggressive, or assertive is really important to define within your own character, and how you can then navigate working with others in communities, with individuals,
Yeah.
within hospital trusts and organizations. You
Yeah.
have to know you.
Yeah. That also
And
takes me
sorry,
great. No, I was gonna finish what you were saying because I was gonna go on to the next question because it led really well, nicely.
I was just going to add that aligning with the right people is really important.
Yeah. Yeah. The next question is, what role does community outreach play in your work, and how do you engage specifically with Black communities?
How do I engage specifically with Black communities? I say who I'm talking to. So a lot of, I say a lot of, I'm not great with social media, but the videos that do go out, I will identify who it is I'm talking to, and that is Black mothers, women, girls, birthing people. Or it may be that I'm speaking to marginalised or minoritized disabilities, neurodivergency. I'm clear about the demographic of people that I serve.
Yeah.
How does, what's the other part of the question? How does it help?
Community outreach. Yeah.
Networking. Networking. I actively seek collaboration rather than competition.
That's very, very
We will
good.
there will always be people giving birth. That's never going to stop. There may be famines, there may be war, there may be disease, but through it all, people are still going to be giving birth. Life is still coming into the world. So there's always going to be a part to play, and there is plenty to go around. I don't want to burn out trying to help everyone. It makes more sense to support many and make more meaningful change and difference by working collectively rather than against. And I spend a lot of time trying to pull quite a few organizations together, facilitating introductions and things like that so that we can all work together.
The next question is, are there any specific policies or systemic changes that you advocate for to improve Black maternal health outcomes?
Consent and choice, mental health, and induction of labour. So I ran the Not So Nice campaign back in 2021, and challenged NICE, to which actually the directors came back. It was a huge grassroots campaign, and it started with me moaning at my husband in the kitchen and him saying, well, you can moan at me or you can do something. And that was probably the real turning point for me in activism. And that's when I kind of got loud. And a big one for me is intergenerational trauma. as
Yeah.
well. That's my next big baby. I mean, I'm a PPI for the puppy study, and I'm also part of the team for the birth experience study via King's College. I'm hoping to write a paper starting end of this year, beginning of next year, with the wonderful Dr. Claire Feely. And then maybe finish this book. And then maybe do my PhD. But I think it's you have to have community.
Yeah.
It can't exist without it.
Yeah. So we're going to head on to the last two questions now because I've taken up a lot of your time. But this also is just perfectly to kind of round off as well, as this has been like a recurring theme throughout our conversation. How do you address the impact of generational trauma and historical medical mistreatment on Black mothers' trust in the healthcare system?
How do I impact it?
Yeah, I can say it again if you'd like. How do you address the impact of generational trauma and historical medical mistreatment on Black mothers' trust in the healthcare system?
Openly, with a lot of transparency. It's not a conversation that is trending. It's not a conversation that is had appropriately. It's not a conversation that people are really open to at the moment. And that's because it can open old wounds. There's a lot of vicarious trauma that can be experienced. But I address it mostly as a solution-based conversation. So because it's such a volatile topic and it's so vast, it can open wounds that people don't necessarily know how to deal with, and other providers may not have the tools and resources to then support them with. So the reason there isn't as much of my work on that publicly is because there needs to be a close, there needs to be a solution, rather than opening up old wounds and leaving people vulnerable.
Yeah.
So being very clear when I do talk about it, and why, where it's coming from, how it's passed down and transmitted, how it then manifests. But there always has to be, how can we work through it?
Yeah, definitely. And then last but not least, how do you ensure that your resources and support are accessible to Black mothers from diverse socioeconomic backgrounds? Do you find the postcode lottery has an effect on people's experiences?
So I always try to seek funding so I can offer it for free. So when it's outwardly, and I know that I'm not always going to be able to do that, but for example, with Black Maternal Mental Health Week, the intergenerational trauma, no, that's not what I'm doing actually for that week. I think I'm doing protecting Black mental health, maternal mental health. That one is free. And I will reach out to my network to say, here, this is what's available. Share it with those that are deemed hard to reach, but there are just so many societal barriers. And there is the next one after, no, I think it might be before. I'm sorry, I've got the dates all jumbled up in my head, but there is one on intergenerational trauma and ACEs and domestic abuse. Again, it's being provided for free, but without me devaluing myself. I will find either the organization will cover the cost, or I will apply for funds, or they may apply for funds, similar to the work with SANS. If I'm commissioned to do something as well, I will always push for it to either be free, or, because sometimes free isn't always best, because people may not see the value, but at an accessible rate, rather than expecting mothers and birthing people that are obviously those living in affluent areas that are socially economic, they've got the finances and resources, they can afford it. But if we're talking about a mother who again, let's pick an asylum seeker who doesn't have anything, doesn't have any access to funds, and maybe fleeing abuse or a war-torn environment, that's not going to be a priority for them, even if the outcomes and the objectives that they'll receive are, it won't be deemed as that because money is a priority because you need to eat.
Yeah.
So providing it free or very low costs will remain a priority. But equally, I always take into consideration the impact on me. I have 4 children too. I am a mother. I also have chronic disabilities and illnesses, and I'm running a business. So it's balance and having firm boundaries, which takes a lot to overcome any imposter syndrome. But again, therapy is great for that, or even coaching, to be honest. So yeah.
And then how do you feel that the postcode lottery has an effect on people's experiences?
Hugely so. If I guess the benefit of experiencing a pandemic like COVID, it's meant that there is more online education, more online support, more online resources, which then to a degree can allow it to be accessible in other ways. However, it does have its own limitation and boundaries, which if people don't have access to the internet, it poses the same issue. But for the greater majority, being able to offer these things online means that more people can access it.
Yeah. Thank you so much for your time. This has been genuinely such an incredible conversation. You are a literal genius.
Thank you.
And
Thank
I
you.
wish you luck with everything in the future. I will make sure to send a kind of doc copy of everything that I include, just to make sure that you give me the green light and are happy with everything that I include. And yeah, thank you so much for your time today. I really, really appreciate it.
No problem. So how far are you into your studies?
I'm just starting second year now. I'm back at uni now and it's fresh as a week, and there's obviously a lot going on, as always, every year. But yeah, I'm excited to get started. I'm sure it's going to be, everyone always says that second year is the hardest year. I'm scared if that's going to be true, but I'm hoping it will be fun.
And how are you protecting yourself whilst doing this work?
That I haven't even considered, which is interesting. What would you best recommend, or do you feel like that's a mandatory, necessary, something that has to be included?
It's not mandatory. I think it should be, and I think it needs to be a conversation that's had with even the lecturers. I feel like that this should be a topic of discussion fairly early on, because education can also cause burnout. The fact
100%.
that as a Black woman or a woman of colour, you are doing such emotive work, although it's education and not the physical outcomes, you're still susceptible. And I think it's really important to protect yourself.
Yeah, definitely. I mean, I do try and do like the kind of baseline things, obviously, in terms of having boundaries with work, having kind of explicit times to like rest and all of that kind of stuff, which sometimes I do compromise on, but I'm trying to make more of a conscious effort to not. And then, of course, spending time with friends, family, etc. So yeah.
Try and incorporate debriefs as well. So I only mentor 2 at a time. I only have 1 PhD student at the moment. But if you, again, this is my way of being able to give back. If that's something you want to consider, then please let me know. Because even if you're just debriefing after hearing topical conversations, it's still very important. It may not feel like it's stirring up any emotion for you personally, but it can manifest longer down the line, and you don't want to compound any feelings or grief that it may cause. So just be mindful and take care of yourself.
I will. I also try to journal sometimes. That's something that I'm struggling to like kind of stick to as more of a routine thing. But I feel like that can also help as like a place to like dump and debrief as well, if not in a physical person. But yeah.
Accountability. Yeah.
Yeah.
Well, I am I will let you know. But if I do get around to setting it up, it will be for students that are in this field, that maybe need the accountability, but also someone that can relate to the work that you're doing and how it's impacting you and what positive techniques they use. And it's not all doom and gloom. It would be positive, but also with the support there readily available if needed.
Yeah, perfect. Thank you so much again. This has been such an interesting conversation. Yeah.
You're welcome.
Thank you.
You too. Take care. Bye-bye.
Bye.